let's talk a bit about um, the function of erythrocytes and their number too, and what does MCH and MCV mean?
Erythrocytes, or red blood cells, RBCs, primarily function to carry oxygen from lungs to tissues and transport CO2 back to lungs for exhalation, thanks to hemoglobin. They number about 4.559 million per microliter in adults, varying by sex and health. MCH, mean corpuscular hemoglobin, measures the average amount of hemoglobin per RBC, typically 2731 picograms, showing how much oxygen carrying capacity each cell has. MCV, mean corpuscular volume, measures the average size of RBCs, usually 80-100 femtoliters, indicating whether cells are normal, small, microcytic, or large, macrocytic. Low MCH might suggest low hemoglobin, like an iron deficiency. Low MCV could point to microcytic anemia. High values might indicate B12 deficiency or other issues. Together, they help diagnose anemia types. Want to connect this to erythrocyte production or dive into anemia specifics?
So MCH is mean cell hemoglobin and MCV is mean cell volume. Okay. Let's talk a bit about erythropoiesis. So, developing red blood cells. During embryogenesis, in what locations do we see this?
Erythropoiesis, the process of red blood cell production, occurs in different locations during embryonics. In the early embryo, it starts in the yolk sac around 2-8 weeks of gestation, producing primitive red blood cells. By 6-12 weeks, the liver and spleen take over as primary sites, making definitive red blood cells. From around 12 weeks onward, bone marrow gradually becomes the main site, dominating by late gestation and continuing after birth. These shifts reflect the embryo's growing oxygen demands and developing organs. Want to explore how erythropoiesis drives this or move to post-birth erythropoiesis?
Um, well, that's okay. Let's talk about stem cells now. So we have multipotent stem cells, then they become progenitor cells, then lineage committed, and then eventually mature. Explain this process to us, and then let's talk a bit about myeloid and lymphoid progenitors.
Stem cells in blood production start as hematopoietic stem cells, HSCs, in bone marrow, which are multipotent, meaning they can differentiate into various blood cell types. HSCs divide into progenitor cells, which are more restricted in potential. These progenitors become lineage committed, locking into specific paths, and eventually mature into distinct blood cells like erythrocytes or lymphocytes. The process, called hematopoiesis, involves HSCs give rise to two main progenitor types, myeloid and lymphoid. Myeloid progenitors develop into red blood cells, platelets, granulocytes like neutrophils, and monocytes, macrophages. Lymphoid progenitors produce lymphocytes, including T cells, B cells, and natural killer cells. Growth factors, like erythropoietin for red blood cells, guide differentiation. Myeloid cells handle oxygen transport, clotting, and innate immunity. Lymphoid cells focus on adaptive immunity. Want to dive into specific growth factors or stem cell regulation?
Explain to me erythropoietin dependent and iron dependent stages or erythropoiesis.
Erythropoiesis, the production of red blood cells, has stages dependent on erythropoietin, EPO, and iron. EPO-dependent stages start with hematopoietic stem cells differentiating into erythroid progenitors, specifically burst-forming unit, erythroid, BFUE, and colony-forming unit, erythroid, CFUE. EPO, a hormone from the kidneys, binds to receptors on these progenitors, promoting their survival, proliferation, and differentiation into erythroblasts. This is critical early in erythropoiesis, as low oxygen levels trigger EPO release to boost red blood cell production. Iron-dependent stages come later, during erythroblast maturation into reticulocytes and mature red blood cells. Iron is essential for hemoglobin synthesis, as each heme group in hemoglobin requires one iron atom to bind oxygen. Iron is incorporated in the bone marrow, where erythroblasts take it up via transferrin receptors. Without enough iron, hemoglobin production stalls, leading to immature or defective red blood cells, as seen in iron deficiency anemia. In short, EPO drives early progenitor growth, while iron is crucial for hemoglobin formation and later maturation. Want to explore how EPO is regulated or iron's role in anemia?
Let's talk a bit about reticulocytes. I don't understand what they are, what their function is, how the name relates to function and structure.
Reticulocytes are immature red blood cells, just one step before mature erythrocytes. They form in bone marrow after erythroblasts lose their nucleus, still containing some ribosomal RNA, which give them a reticular, net-like appearance under a microscope, hence the name reticulocyte. Their main function is to mature into fully functional red blood cells within 1-2 days in the bloodstream, completing hemoglobin synthesis to carry oxygen. They make up about 1-2% of circulating red blood cells, and their count reflects the bone marrow's red blood cell production rate, useful for diagnosing conditions like anemia. The name reticulocyte directly ties to their appearance, not their oxygen-carrying role, but their job is to finish maturing to do that. Want to dive into how reticulocyte counts are used, or their role in specific diseases?
Well, so reticulocytes want to become red blood cells. Okay, tell me how they connect to anemia. Tell me about methemoglobinemia.
Reticulocytes are immature red blood cells, and their count in the blood cells diagnose anemia. A low reticulocyte count in anemia suggests bone marrow isn't producing enough red blood cells, like an iron deficiency or aplastic anemia. A high count indicates the marrow is compensating for blood loss or hemolysis, as in hemolytic anemia. Methemoglobinemia is a condition where hemoglobin's iron is oxidized.
So iron is oxidized. And why is the iron oxidized? I've told you many times, if you hear me speaking in another language, it's wrong. I'd never do that. Just acknowledge it and speak in English.
My bad. I hear you sticking to English. Let's clear this up. In methemoglobinemia, the iron in hemoglobin's heme group gets oxidized, meaning it changes from the ferrous state, Fe2++, to the ferric state, Fe3++. Normally, Fe2++ binds oxygen for transport. Oxidized iron, Fe3++, can't bind oxygen, so methemoglobin can't carry oxygen effectively, reducing oxygen delivery to tissues. This can happen due to genetic defects, certain drugs, or toxins. Want to connect this to anemia or dive into symptoms of methemoglobinemia?
I want to understand how the name methemoglobinemia shouts oxidation of iron.
The name methemoglobinemia breaks down to reveal the iron oxidation. Hemoglobin refers to the oxygen-carrying protein in red blood cells, with iron in its heme group. Met comes from a Greek term implying transformation or change, here signaling the altered state of iron. In methemoglobin, the iron is oxidized from ferrous, Fe2++, which binds oxygen, to ferric, Fe3++, which can't. Methemoglobinemia means in the blood. So, methemoglobinemia literally means blood with hemoglobin in an altered, oxidized state, spotlighting the iron's oxidation that cripples oxygen transport. Clear now? Want to
No.
explore causes or effects of this condition?
This is not clear to me, to be honest.
No worries, let's simplify. Methemoglobinemia means hemoglobin's iron has changed from its normal form, Fe2++, to an oxidized form, Fe3++. The met in the name points to this change, and emia means it's in the blood.
Okay. And why don't we talk a bit about polycythemia too? What's this physiologic polycythemia and polycythemia vera? Does this mean that we have many red blood cells? Why is that a bad thing?
Polycythemia means having too many red blood cells, which thickens blood and can cause problems. Physiologic polycythemia is a normal adaptation, like in people living at high altitudes, where low oxygen triggers more red blood cell production via erythropoietin to carry enough oxygen. Polycythemia vera is a disorder where bone marrow overproduces red blood cells uncontrollably due to a genetic mutation, often JAK2, not a response to low oxygen. Both
Wait,
increase
so
red
why is it bad to have many red blood cells? And what's PCV?
Too many red blood cells, as in polycythemia, thickens blood, making it sluggish and increasing the risk of clots, which can lead to strokes or heart attacks. It also strains the heart and can cause high blood pressure. PCV, or packed cell volume, is another term for hematocrit, the percentage of blood volume made up of red blood cells, normally 40-50% in men and 36-46% in women. In polycythemia, PCV is high, reflecting the excess red blood cells. Want to dig into how polycythemia vera is managed, or more on hematocrit?
I still don't understand why I need to have, why having a lot of red blood cells is bad. And tell me again. Yeah.
Having too many red blood cells, like in polycythemia, is bad because it makes blood thicker and stickier. This slows blood flow, raises blood pressure, and increases the chance of clots forming, which can block vessels and cause serious issues like strokes or heart attacks. It also puts extra strain on the heart to pump this thicker blood. PCV, or packed cell volume, also called hematocrit, measures the
Guys,
percentage
sorry, I got attacked by a bee. Perhaps if you could tell me again, dude.
Ouch. Hope you're okay after that bee attack. No worries. Let's hit it again. Too many red blood cells in polycythemia makes blood thick, like syrup, which slows flow, raises blood pressure, and risks clots that can cause strokes or heart attacks. It also overworks the heart pumping this heavy blood. PCV, or packed cell volume, same as hematocrit, is the percentage of blood made of red blood cells, and it's high in polycythemia, showing the excess. Clear now? Want to talk polycythemia vera treatments or something else?
That makes sense, actually. Okay. And what about the iron requirements for red blood cell production? Tell me about ferritin, about hemosiderin. Why is this bee? I just moved places. This bee is coming for me, guys. Sorry.
That bee's got a vendetta. Stay safe. All right, let's
Anyway,
dive
tell
into
me
iron.
about this hemosiderin, ferritin, and yeah, what is all this?
All right, dodging that bee, let's talk iron, ferritin, and hemosiderin for red blood cell production. Iron is essential for hemoglobin and red blood cells, as each heme group needs one iron atom to bind oxygen. About 2/3 milligrams of iron is needed daily for erythropoiesis, mostly recycled from old red blood cells. Ferritin is a protein that stores iron in a safe, soluble form, mainly in the liver, spleen, and bone marrow, releasing it when needed for red blood cell production. Hemosiderin is another storage form, but it's less accessible, forming when excess iron accumulates, often in insoluble granules, like in overload conditions. Ferritin keeps iron ready for quick use. Hemosiderin is a long-term storage backup. Low ferritin signals iron deficiency, slowing red blood cell production, while high hemosiderin can indicate iron overload. Want to connect this to anemia or dive into how iron is recycled?
Well, actually, I want to ask you about iron deficient anemia, microcytic and hypochromic. Explain to me the differences.
Iron deficiency anemia happens when there's not enough iron to make hemoglobin, leading to fewer and less functional red blood cells. Microcytic means the red blood cells are smaller than normal, MCV below 80 femtoliters, because low iron limits hemoglobin synthesis, stunting cell growth. Hypochromic means the cells have less hemoglobin, MCH double-side picogram, making them paler since hemoglobin gives the red color. In iron deficiency anemia, cells are both microcytic and hypochromic due to insufficient iron for proper hemoglobin production, reducing oxygen carrying capacity. Microcytic describes size. Hypochromic describes hemoglobin content. Want to explore causes like low ferritin or treatment options?
Well, no, that's so good. And I wanna understand a bit about so
Cool.
with hypochromic microcytic anemia, the cells keep dividing but they can't fill up with hemoglobin, basically. And with folic acid and vitamin B12, what's going on there? So they are important for rapidly dividing tissue and for forming DNA. Deficiency causes megaloblastic anemia, which makes sense. Talk to us a bit about these things, and also talk to me about vitamin B12's um, uh, function on gametogenesis, and tell me about pernicious anemia and hemolytic anemia, lymphoma. It's a lot of things. I'm sorry.
No worries. Let's tackle this step by step, keeping it tight. In hypochromic microcytic anemia, like iron deficiency anemia, red blood cells divide but can't pack enough hemoglobin due to low iron, so they're small, microcytic, and pale, hypochromic, reducing oxygen delivery. Folic acid and vitamin B12 are crucial for DNA synthesis, especially in rapidly dividing cells like red blood cell precursors. Deficiencies in either cause megaloblastic anemia, where red blood cells are large, macrocytic, MCV vial 100 femtoliters, and immature because DNA replication fails, halting cell division but not cytoplasm growth. Vitamin B12 also supports gametogenesis by aiding DNA and RNA synthesis in sperm and egg cell production. Deficiency can impair fertility. Pernicious anemia.
Summarize in a few sentences again everything.
In hypochromic microcytic anemia, low iron leads to small, pale red blood cells that can't carry enough hemoglobin. Folic acid and vitamin B12 deficiencies cause megaloblastic anemia, with large, immature red blood cells due to failed DNA synthesis. B12 is vital for gametogenesis, supporting DNA production in sperm and egg cells. Pernicious anemia results from B12 deficiency due to missing intrinsic factor, impairing B12 absorption. Anemia in lymphoma arises from bone marrow disruption or chronic disease, reducing red blood cell production. Want to zoom in on one of these or move on?
That's so good. Thank you for watching, guys.